Welcome to this webinar. Thank you for finding the time to join us. This is a webinar that we are doing in collaboration with our colleagues from Duke University Center for Policy Impact in Global Health. It is a global project that is led by my colleague, Professor Gavin Nyame, as the PI, and Dr. Osondu Ogboji as the co-PI. It's being undertaken across several low and middle income countries, and Kenya is one of them. And thank you very much for sparing the time to join. The webinar is focusing on driving health progress through the 4 Ds: disease, demographic, domestic finance, and donor transitions. And the purpose of our work is to really generate data, evidence, and analysis that policymakers can use to navigate this transition. The transition is not a different phenomenon. I think those of us from Kenya know that we have our Vision 2030 that really looks at the horizon and envisages Kenya that we are not going to remain small. And you also recollect that Kenya transitioned from a low to a lower middle income country in 2014. That has got a lot of implications on how we then manage our affairs, especially with regard to health. So this is the background. But let's also not remember that in the process, this project started in early 2019. By then, we did not envisage that we would have a pandemic. So the context now has changed slightly with the COVID pandemic. So we would want to present some of the work that we have been doing around this thematic area, but given that context. But also let's not remember that for Kenya, we also have a unique situation where our debt to GDP ratio is fairly high. And therefore, we need to think how that is going to be managed as we also manage the transition. So that's, ladies and gentlemen, this is really the background of our work. The purpose is really not to point to solution, but really to open ourselves to discussions and feedback. I also would want to remind the participants that we are not the only group that is actually taking this kind of work. A large group at the Ministry of Health is also doing similar work. And the purpose is that we should then have a forum where we can be exchanging ideas so that at the end of the day, we come to some consensus on the way forward. Without wasting too much time, we have the privilege of the presence of the Chief Administrative Secretary at the Ministry of Health, Dr. Rashid Aman, to give us his opening remarks. Originally, we thought that Dr. Aman would stay with us much longer, but for those participants who are not from Kenya, this time around 3 o'clock is usually our time also for the brief by the Ministry of Health on issues to do with the current status of COVID-19, and Dr. Aman would want to actually then exit and go and join in the brief. So I had talked to him and assured him that after his brief remarks would allow him to proceed. Now, before I invite Dr. Aman, just a brief. Dr. Aman is the Chief Administrative Secretary in Ministry of Health. He's an accomplished scientist in his own right, a molecular biologist by training, has supported this work that we have been doing in his role at the Ministry of Health right from the beginning up to now. So we are very grateful to Dr. Aman and his colleagues from the Ministry of Health for their support and encouragement. So without too much ado, I would want to now take this opportunity to call upon Dr. Aman to give his opening remarks. And then I will, after that, I will then introduce the presenters according to the program. Dr. Aman, I hope you can hear us loud and clear. I think we have some technical, so while we are sorting out the issue, Dr. Mann, maybe I can take this opportunity now to simply then introduce the presenters, and hopefully by the time I finish, we will have gotten connection with Dr. Mann. So the technical team and Dosila, you can try and find out whether Dr. Mann is able to join. In the meantime, I'll just introduce the presenters. So the presenters, we have a panel of very able presenters, and they will also be the panelists at the end of the session. We have decided that rather than have a quick question and answer, in between, we will leave all the questions and encourage participants to either post questions or in some way find a way of passing the questions to us so that we deal with the questions, all of them at 3:40 discussion. So the general guide for the presenters, let's make the presentation less technical. We have a diverse group of participants. Let's avoid technical jargons. We should make it easy to follow so that we involve everyone. So with that, then we just introduce the presenters. We have Dr. Kenneth Munge. Kenneth is a health policy and system practitioner with interest in economics of health systems and reform, public financial management, and primary care. Ken's experience in analytical and advisory services and policy developments, and he has got experience in analytical and advisory services and policy development, and is currently based in Nairobi, working with the World Bank. And then we have Peter Nguhiu. Peter has just completed his PhD at the Kimberley Wellcome Trust Program, one of our local partners, and is also interested in global financing data and design analysis. He has been doing that for several programs, both in Kenya and across sub-Saharan countries. And then our own Dr. Joseph Onyango. Joseph is a senior lecturer in our Institute of Healthcare Management at Strathmore. Joseph is an institutional development and health system strengthening specialist, specifically focusing on organizational behavior and change, strategic planning, and related issues like human resource management. And then we have from our colleagues at Duke University, Wenhui Mao is a health economist. Wenhui is senior policy associate at the Center for Policy Impacts in Global Health at the Duke University. Wenhui has contributed a lot together with colleagues at Duke University in helping us to undertake the research that we are going, part of which we are going to present here in Kenya. Then we have Ipchita Barali, sorry, Ipchita. Ipchita is an associate in research at the center, the same Center for Policy Impact in Global Health at Duke University. And just like Wenhui, Ipchita has been a close participant, associate in terms of helping us to undertake the work in Kenya and interpret some of the results. So Ipchita is going to also co-present with the JO and part of the work we did on COVID-19. So let me go back to, I'm not so sure whether Dr. Mann has been able to join us. Dr. Mann, are you able to hear me?
Dr. Mann has joined.
Rashid, the floor is yours. We had done some preliminary introductory remarks, and given the fact that you are pressed for time, I had indicated that I would immediately invite you to give your opening remarks. So the floor is yours, Dr. Mann.
Thank you very much, Professor, and all those who signed into this meeting. Good afternoon, everyone. I'm delighted to join you in this virtual meeting as we discuss this most important topic of sustainable health financing. this meeting is crucial, especially because Kenya and indeed the world at large have committed to achieving universal health coverage, which requires adequate and sustainable financing. In 2013, the Kenyan economy was rebased to a middle-income country because of the positive economic growth that the country had demonstrated over the years. Of course, with this transitioning, which is a good thing for us from the economic point of position, it also presented challenges because of declining donor funding with this rebasement. And therefore, it's an awakening for the country to be able to move towards sustainability, to be able to generate enough resources that it can sustain the programs that were originally funded by donors. Donors themselves are increasingly wanting countries to move to a certain stage where they can become sustainable through domestic financing. So most of our programs, health programs, especially the strategic health programs, such as the infectious diseases programs of HIV, TB, malaria, as well as the maternal and child health programs, are those programs that are heavily dependent on donor financing. And these are key programs, primary healthcare programs that would roll us back if we didn't have, we didn't continue to sustain the level of operations that we have established in these areas. So these are key areas that we need to build that sustainability. The attainment of universal health coverage, which is one of our big four agenda, calls for the immediate and long-term commitment of resources to ensure Kenyans access preventive, promotive, curative, rehabilitative services that are of sufficient quality without having experienced financial hardship. This paradigm shift is for the robust investment in all aspects of the health system by all sectors in this area, including the national government, county governments, partner institutions, academic and research institutions, and private sector players. At the same time, the country has also experienced certain other shifts, including the epidemiologic transition characterized by the shift of disease from one that has been prominently communicable conditions to an increasing level of non-communicable conditions. This then presents a double burden to the country. This epidemiologic transition is also coupled by a demographic shift in which we now find more and more people living longer and experiencing increased healthcare needs associated with an aging population. On top of that, currently the country and the whole globe is facing the COVID-19 pandemic, which has clearly demonstrated the need for building resilient health systems. The compounding effect of all of these factors puts on the spotlight the need for adequate resources, including human resources for health infrastructure, equipment, necessary health information, and basically building our health systems and all the building blocks of the health system. Sustainable financing is about prioritization and ensuring adequate funding for these priorities. More so than that, it's not only availing the resources, but ensuring that those resources, the resources that are applied, give you value for money. So we need to have more health for the money that we invest in. And in working towards the advancement of transition preparedness, tackling the challenges of sustainable financing, the ministry put in place a task force to develop a roadmap for transitioning from donor aid to a sustainable health financing. The key mandate of the task force has been to deliver the roadmap through 4 key work streams, including health financing, services and health delivery systems, human resources for health, and commodities and laboratory. The health financing stream output was a consolidation and report of all financing aspects and highlighting the priority interventions, resource needs, resource availability and gaps through a programmatic efficiency assessment, resource mapping, and resource needs modeling, and a review of the Public Finance Management Act. Through strategic partnerships with learning and academic institutions, such as Strathmore University Institute of Healthcare Management, the ministry is leveraging on the additional information resources obtained by carrying out research to explore the resources required for Kenya to achieve progress in health coverage amidst challenges in demographic, disease profile, and resource envelopes. It is my hope that we will continue on this trajectory of beneficial partnerships to ensure delivery of quality health services to all Kenyans. With that, I want to wish you all good deliberations, and I also want to ask you to excuse me to go and move on to the next task now, but I know that you are all set up now to discuss this very, very important topic. That's one of the priorities that we are addressing as a ministry. Thank you. Professor, over to you.
Thank you, Dr. Mann. And again, thank you for sparing the time to actually be with us. We will not keep you longer than necessary. We had hoped that you would be joining us for the rest of the thing, but if there are questions that you would have help us to clarify, I think we'll find a way of dealing with them. Thank you very much. We will give you a report, a full report of the proceedings. And once again, thank you very much for the time and the support. And we wish you well. I'll give you a report. Thank you.
And good deliberations. Thank you.
Thank you. So, ladies and gentlemen, I think we now go back to the program schedule. Allow me just to summarize what the CAS has said in one sentence, that the work that we have been doing with our colleague from Duke University is aligned to the broader government agenda. He went on to explain that the ministry has put in place a task force. And in fact, he has encouraged us to work closely with the task force, our team, to work with the task force so that we can come to common understanding on the way forward. And this is really useful. It's always a criticism, especially from policymakers, that researchers, we come back with things that we think are more interesting in terms of exciting academic curiosity, but are not aligned to the country's priorities. In our case, we are very happy that this is so, and not only that, we are actually getting the necessary support from the Ministry of Health. So now it is time for us to go to the main presentations. Again, I'll introduce the presenters, just to remind the presenters that really what we want this is a general dialogue. Let's make it as participant friendly as possible. Let's avoid technical jargon, and more importantly, let's keep to time so that we have enough time for discussions. For the participants, please post your questions. We already have some written questions which we received yesterday. We expect more so that we can then participate in some robust discussions after that. So without too much ado, now I would want to call upon Peter to give us his presentation. Peter, over to you.
Right, thank you very much, Professor Kwakwaro. And I'd want to really say that what I present is really in line with what the Honorable Chief Administrative Secretary has mentioned before. Without any further ado, I'm hoping that you can all hear me. Again, thank you very much for this opportunity. I'll be presenting on the modeling work that we did together with the Duke University team, Strathmore University team, looking at resource estimation towards UHC in Kenya. So in background, you heard about the transitions that we mentioned, the demographic transition, mainly known if you've listened to transitions around the recent census, you've heard that there is an increase in the life expectancy in the country, and that we actually are having a shift, that our population is living longer. In addition to that, we are moving towards a more prevalent non-communicable conditions, and that in itself bears a burden for the country in terms of the resources allocated towards health. So in addition to that, heard about the movement towards the LMIC status, and with it, transition in the nature of financing for health in the country. All these pose a couple of challenges for the country, but poses opportunities for the country to determine the path towards sustainable financing. So for this piece of work,
I think we have lost Peter. We have lost Peter there. So
sorry about that. It just so happens that sometimes when you really want to present something is when a connection fails. But I've switched on to another connection, and I hope that that works better.
Okay.
Just to check whether you can all hear me. All right.
We can hear you. Okay, fine.
So, so our task was to determine the current resource requirements and to model the changes in these requirements as we experience a demographic and an epidemiological change. So there were three things that we did, and these are in the next 3 slides. First is we had to define the interventions to focus on. So we took a subset of essential services in 4 areas. This is in reproductive maternal child health, in communicable diseases, this is HIV, TB, and malaria, and in non-communicable diseases and injuries. We went ahead and verified the demographic and disease modules in terms of what projections they were producing, and to calibrate this with our country's current census data. We configured baseline and anticipated target coverages. And all this was done using the One Health tool, which is a dynamic modeling tool that is used to estimate demand for health services from a system-wide perspective and from program-specific perspective. It's a modular tool, and there's a link at the bottom of this presentation that you can actually read more about that. We made some assumptions, some costing assumptions, in order to estimate resource requirements. So the scope for the costing was 10 years from 2021 to 2030, based on the projection. And we focused on facility level services in the aforementioned domains of care. We excluded above service costs for now, and focused on costs incurred from the point of view of a health provider. So the perspective of costing was a health provider perspective. And we estimated the total costs of provision of these services, although we could also then compute the additional expected requirements based on this. We developed 3 scenarios, one with status quo growth in intervention coverage, and the other 2 based on a percentage increase, okay, at 5 absolute percentage points increase in the annual rate of change, versus the 3rd scenario, which was the most optimistic scenario, where all interventions were required to reach 95% coverage. And these are, one example of such projections is shown on the screen here, with the blue line representing the 3rd scenario, the least ambitious scenario, and the gray line representing the most ambitious scenario. In the next few minutes, I will present the key findings that we have obtained and then give a discussion. For the key findings, we have findings in terms of resource needs and findings in terms of health outcomes obtained. For resource needs, the key information that we can see is that these estimates are exclusive of program level costs, as we mentioned. So they are lower than the overall expected budget for the country. And this, we arrive at scenario 1, expecting a moderate increase from the current $470 million to about 473, while scenario 1, the most aggressive scenario, looks at an increase from about 470 to about 587. And these are specifically facility level service delivery costs, excluding infrastructure and HRH development costs. As far as health outcomes are concerned, we can see that the scenario 1 also provides us with more health outcomes. These are measured in various ways. These are valued, well, they're not yet valued, but they are measured in and converted to utilities. And we can see that maternal and neonatal health outcomes, the first two over here, seem to be lower in the more aggressive scenarios, purely because of demographic shifts, leading to a lower rate of birth. But then also non-communicable disease health gains are really large, again, because of the demographic shift in the first two scenarios compared to the third scenario, which is moderate expected changes in coverage. The key implications from this work is that we find that there is benefit in increasing coverage aggressively of essential services, because we get gains in years of life saved, gains in disease-adjusted life years averted. But it requires us to put in more resources for service level provision of services. And this requires political goodwill, as the Honorable Kath has mentioned, and it requires resource mobilization, especially domestic resource mobilization for sustainability. But as these investments are made, we expect that there will be transition in epidemiological profiles, which will then expose larger gains, especially in the areas that we're currently really concerned about, the non-communicable diseases area. And we'll also experience a demographic dividend that comes from that. Thank you very much for that. This is just a brief picture of the work that we've done. I want to acknowledge a wide range of members, as listed down here, who have provided input directly and indirectly to this particular work, and who continue to provide inputs. Thank you very much.
Thank you, Peter. Thank you. And to the participants, you can post your questions specifically for Peter. It would be nice if you also indicated where you are coming from, and we'll be able to sort those out. But for purposes of managing time, we shall defer the Q&A session to the later session. So let me now take this opportunity to invite Ken, Dr. Ken Munge. Ken, you are ready?
I am, Prof. Thanks so much for the kind introduction.
Perfect. The floor is yours.
So, so my presentation is on behalf of my co-authors, and particularly Casey McDade, who really led this work and who's away on leave. And I will get straight to the presentation, which is really on donor dependency and concentration in Kenya's health sector within this broader program of work looking at transition. A quick disclaimer, and really thinking through what the overarching goal during transition is. We really want to make sure that we can maintain and even improve effective coverage of health services. And by effective coverage, we have a very specific meaning. We mean that everyone is still having access to services, but they are also of a good enough quality to benefit them. So those two issues are very important. So not just making sure people are accessing services, but making sure they have good enough quality. And this study that we did is part of a set of analysis. And you can see the other publications there on the Center for Policy Impacting Global Health website. And we aim to look at Kenya's health aid landscape and understand if there are vulnerabilities given Kenya's ongoing transition from aid, as has been discussed by Vikas and Peter and framed by Prof. Kokwaro. So we really focused on two key concepts. So the first was on donor dependency. And we defined this as whether a country is likely to have the capacity to fill a funding gap caused by a donor exit. And because this concept doesn't exist currently in literature, we came up with a measure that this would be the ratio of external funding to domestic public sources. And pretty much the thinking is that it would be difficult for a country to meet withdrawal of external funds that were greater than 25 cents for every dollar spent by the country. And then in donor concentration, our main focus was where only a few donors make up the majority of aid received. And again, for this, because this is not a concept that's in literature, we came up with this measure that this is when less than 20% of donors make up more than 50% of overseas developmental assistance. And we performed the analysis across the health sector and within health subsectors, which are mostly functional, as we will see in the presentation. And more details on how the calculations were done, where the data was obtained, are in the working paper, which is available online. So quickly into donor dependency, and we found that Kenya does face substantial, if declining, donor dependency across its health sector. And that's what that table there summarizes. And if you look at the donor dependency ratio, which is the bottom row in the darker blue, you can see the donor dependency ratio is greater than 0.25. So it's actually 0.6 in 2015-16, which is the last year for which we have data. And dependency is a particular concern for development budgets at both national and county level. And we also found that donor dependency is an issue in key subsectors of the health system, particularly in the management of priority conditions such as tuberculosis, HIV, and in priority services such as immunizations. With regards to donor concentration, I think this is no surprise to anyone that 4 donors dominate the ODA space in Kenya. That's the US, Global Fund, the UK, and Gavi. And the US government in particular is a unique case because it's one of the largest donors to the Global Fund and is one of the largest single country donors to Gavi. And ODA mainly dominates in STD control, which includes HIV/AIDS, and makes up greater than 50% of the support in this area, and is also a big player in malaria, provision of basic healthcare, particularly immunizations, health policy and reproductive health. And you can see that in the pie charts shown there, which I extracted from the working paper. And you can see the contribution in a darker shade of orange of external sources to these main subsectors, if you'd call it. And you may think that, well, the domestic resources are a major share of malaria and reproductive health, but the truth is, if 1/5 of your funding was withdrawn for a particular program, that would have major implications on the ability of that program to deliver services of wide enough coverage, as in with enough people accessing it, and of sufficient quality. So what are the implications of our results? So it's clear that some donors play an outsized role in financing Kenya's health system and key parts of its health system. And the graph extracted again from the working paper shows what can happen if domestic priorities change. So this is tracking PEPFAR's allocations to HIV, the HIV response. And in 2013, there was a major dip in the budgetary allocation, which then picked up in the subsequent years. But this kind of unpredictability is really, really worrying. And of course, a country is much more vulnerable if there's great concentration or dependency. So one of the other concerns is that the transition plans of some of the donors are concerned more with replacing just the financial aspects of these programs, which is not sufficient. And it was really heartening to hear the CAS address this, that we have to look at both human resources, information systems, the other elements that help us deliver services to people. So what are our recommendations? So one, we do need to proactively prepare for transition, and this is it's important that the Ministry of Health has gone ahead to prepare this strategy, and now we really look forward to implementation. And one of the things that will be required in implementation is simply an increase in domestic resources for health, because one of the possibilities is that as donors withdraw, the financial burden might be transferred onto households through out-of-pocket payments, which is exactly the direction you do not want to go. Addressing health system inefficiencies will require, some very hard decision-making about, what to do about individual programs, what to do about particular services, what to do about particular, positions. And it will be interesting to see, how that plays out over the next few years. A key area for both Kenya and external partners is to improve the tracking and reporting of reliance on health aid. I think in the study, it was quite startling just how little data there is out there on exactly who is doing what, especially in publicly available domains. And I think finally, the key donors should really identify clear pathways for transition that reflect this focus on effective coverage and not just on transferring the financial burden to the recipient countries. So thank you very much, and I look forward to engaging with you.
Ken, thank you very much. We have to defer the Q&A to the next session. We are running, I think, 5 minutes late. So I request Dr. Nyango to try and maybe just make the next presentation very brief so that we have enough time for Q&A. Joseph.
Good afternoon, good morning to all the participants. So while we were working on those first two presentations, we were struck with COVID, the global pandemic that we are going through. And with that, then we had a third stream of our initiative. And this was to around understanding the impact of COVID-19 on Kenyan health systems and determining the pathway for improving future health emergency preparedness. So this part of presentation will be led with my colleague from Duke, and I will welcome Ipita to take the presentation.
Thank you so much, Dr. Joseph. Today, me and Dr. Joseph will be presenting some of the emerging findings from a qualitative study that we have been undertaking over the past 6 months. So first, we'll be giving you a brief background about the study and introduction to some of the methods. And then Dr. Joseph will be presenting some of the key findings and emerging recommendations. So in the next slide, so just to give you a background, so it's been over a year since the first COVID-19 case was detected in Kenya. And now we see that after a year, the number of daily cases in Kenya are again at an all-time high of over 1,400 cases per day being detected recently. And even as Kenya has started its vaccination program after receiving over 1 million doses from the COVAX facility, there are still issues around being able to control the spread of the pandemic. We started doing some work around understanding some of the middle-income countries' policy responses to the pandemic. And so in August 2020, we published a policy report that highlighted some of Kenya's early policy responses to the COVID pandemic. So continuing that work, we undertook this qualitative study to again have a better, deeper understanding about the key impact of COVID-19 on the country health system, as well as how it has helped to, or in a way, like determine the policy priorities in the long and short term. And we also try to highlight some of the risks, some of the recommendations, as well as lessons for Kenya from its own experience, as well as the experience of other countries that are handling the pandemic. So in the next slide, we talk about some of the methods. So this was a qualitative study where we undertook 16 virtual interviews with stakeholders representing the government. So we talked to national and subnational county level government policymakers. We also interviewed donors and development partners, healthcare professionals, as well as stakeholders from the non-government sector. So the interviews were recorded, they were transcribed and using NVivo. And so here, I'll be passing it on to Dr. Joseph to present some of the findings and recommendations.
Thank you very much. So in terms of the results around health system preparedness, most of the respondents agreed to the fact that the initial response by the government and the stakeholders was relatively good, irrespective of the fact of a number of challenges that were incurred. So again, a number of concerns were relayed across board around service disruption on the general healthcare services, cutting across primary healthcare, reproductive health, HIV, TB, and non-communicable diseases, and also part of that associated with elements of stigma. Areas around coordination between the national government and the county government, the flow of resources and all that, there were challenges around that that were recognized. Again, in terms of human resource for health, there were stretched healthcare professionals, lack of protective equipment, the testing kits, all those were challenges that were recognized as affecting the preparedness of the country to respond. And so with that, then, as you can see, part of the extract from the working paper that we have that will be published out soon, you can see what from one of the respondents is indicated there around the ability of our health system to respond to the global healthcare, challenges that is to a greater magnitude, defining how we test, and actually our systems are put into test as to whether we are essentially prepared to manage a pandemic. The other element that was tying in with what Dr. Ken and Dr. Peter presented was our healthcare financing, because with the emergence of this pandemic, then disruptions there and constraints around financing healthcare, and majority of the respondents at a very high level are to the fact that it's a fact, again, that the healthcare is inadequately financed, and coupled with a pandemic, then the situation is worsened. But also the respondents were of the view about the utilization of the resources, and part of this was also available in the public domain around how the resources that were available towards the containment of the pandemic are being utilized. And also a quote there from one of the respondents that the outright answer is our resources have not been enough, which is a fact, and then both financial supplies and so on and so forth. So this to a greater extent then affects the level of availing services as we have this pandemic. And then the other stream, again, linking up with what Dr. Ken has presented, donor response and coordination. Again, the respondents lauded the effort of the various stakeholders and actors and agencies is coming together on a common front to mitigate the pandemic, both at a local level and at an international level. So again, we are realizing that the development partners then have to repurpose their funding respond to this pandemic, which then that then brings another constraint in the general provision for healthcare services. So again, concerns relayed around COVID-19 on donor transition, because as we are transitioning, and I think this was emphasized with the task on his opening remarks, we are now at a dilemma on how are we going to proceed with financing our healthcare with the donor transition amidst a pandemic. And again, what there, in terms of most countries having experienced the pandemic and economic crisis, which they have not had in the past, we expect that they will focus more on their individual countries, because we have the development partners with their own countries and sharing their resources with the developing countries. Then we are then put at a situation where we have to rethink our our financing and our dependency on donors. So in terms of broad emerging recommendations that we will be validating going forward as this paper get published and being utilized for policy direction around health system preparedness, applying the novel strategies on this domestic response and lessons learned from countries, because our countries are unique. So testing home-based care for patients, with mild symptoms, improving training for health professionals, and improved contact tracing. So a recommendation around that, leveraging on bilateral and multilateral relationships, as we can see, even how we are getting our vaccines and ensuring that the wider population is vaccinated. Then strengthening the intergovernmental coordination between the national government and the county government, a recommendation around that. When we move to healthcare financing, a recommendation around creating an emergency fund to curb any pandemic that may emerge, as we don't know of what the next pandemic that will strike us, and then increasing the financial accountability on the funding that is available for us, domestic investing, and I think this has been echoed with the presentation from Ken and Pete as well, reviewing our public finance management laws so that we ensure that there is an expedited way of responding to the pandemic based on our procurement and availability of services as guided by the laws. Then on the donor response, as I conclude, and coordination, the need for stronger collaboration and coordination around the donor fraternity, within the donor community themselves, and then the governments and the donors. And then relooking at our transition framework, also increasing equity and resource allocation going forward, because we have so many programs around healthcare, and most importantly, towards achieving our universal health coverage, and then finally prioritizing the key healthcare programs that are highly affected this particular time that we have the pandemic. So ladies and gentlemen, we will be welcoming questions and areas that we need to enhance as we work on this policy paper. Thank you very much. Over to you, Prof.
Thank you, Iptita and Joseph. Thank you very much. So ladies and gentlemen, we now want to go to the next part of the program, which is question and answer. We have just slightly over 30 minutes, 20 minutes actually for Q&A. So unfortunately, we will have to shift through questions that we can take and see how we best to answer that. Yes. Okay, so the panelists, my request is that presenters, you be prepared to then act as the panelists, and also I'll be bouncing this off so that I'm not accused of hijacking the discussions. But in the interest of time, I would request the panelists, please, if any of the questions has already been addressed, just give a brief response. So the first one, if you can allow, let me start with a few questions that were sent to us yesterday, even before that. One is coming from Irene Chemi, World Federation of Hemophilia in Kenya. Irene says as follows: a large percentage of the health budget in Kenya is funded by donors. It's true. This has been the case for many years. What could be the reasons for this? I hope Irene is listening. Also. Ken, what could be the reason? I hope I've not taken you off guard, Ken.
No, you haven't. I guess it's a complex, well, not very complex question. I guess it has a lot of historical antecedents. And I think if you think back to, very far back to, concepts around, primary care and so on, and the birth of vertical programs like the immunization program. And one of the early ones was in a sense, successes sometimes breed problems. So the success with the smallpox program built the argument for the expanded program for immunization, and this was then introduced mainly as a vertical program, so running parallel to the system, but to deliver a particular service. And it gained a lot of success, but it was at odds with a lot of the conceptualizations around how service delivery should be offered. And unfortunately, this was never fully addressed because of other things that were happening at global level, including, the Cold War and how governments thought about where, the space of governments in the provision of services. And then what happens in the late 80s to early 90s is the emergence of HIV, and that sort of cemented the role of vertical programs. And I think the entry of global philanthropy also played a part. And then you do have, of course, weaknesses, for example, in democratic institutions, just weaknesses, not necessarily many that, are playing out. I think in Kenya, we are well aware of what it means for constitutional dispensations to slowly evolve over time to allow governments to be more responsive to citizens. So I think it's a mix of things in the global arena, in the local space, related to both the health sector and outside the health sector. Over.
Ken, stay on. So I'll do it this way. There's another question for you, Ken. If you can just stay on, huh? So someone
right.
It comes from Dr. Mulongo, Nairobi. So Daktari says, Dr. Munge, did you find any insights on domestic financing of health research as donor concentration is significant in Kenya?
So to my recollection, we weren't really looking at health research. There was, and again, this was really restricted by the amount of information that is there. And we were really focusing on financing that is on budget or at least reported through the health accounts. And you will find that at least in the health accounts, the contribution of research funding is not very clear. And that was why one of our recommendations is really that space in terms of documenting what goes into various areas in terms of ODA needs to be better tracked and reported on. So that is one of the challenges for sure. Okay.
Thank you, Ken. So let me go to another question we got yesterday, and I don't know who is. This is from Lynn Kua, Community Partners International. What kind of learning from Kenya's experience can be transferable to Southeast Asia region? Oh, wow. This is Ipchita. Have a go at this one. What kind, I'm not so sure, I'm not putting on the spot, but it says, what kind of learning from Kenya's experience can be transferable to Southeast Asian region?
Yeah, thank you, Dr. Kokwaro. I think if we specifically look at the example of just COVID-19, I think some of the early responses of the government have definitely been very effective in terms of responding to the pandemic, whether it was setting up some of the task force in terms of the measures that were adopted to control the pandemic. I think there are cross lessons from across the continents, whether it is South Asian countries learning from Kenya's experience or some of the countries who have experienced pandemics in previous years. But then also, I think there are, in general, lessons that can be learned in terms of the ways in which transition planning is being handled at the early stages in Kenya. And this would, of course, require dialogues between the donors as well as the government in terms of identifying the strategic priorities, but also at the same time trying to take measures to understand some of the resource needs, as well as trying to understand how best they can be working during these early stages to prepare for donor exits. So I think broadly, I would say that trying to learn lessons from the way in which Kenya is trying to look forward in terms of how to take this journey towards self-reliance. Thank you.
Thank you. Let me put a further question. One of my colleagues, Professor Edwin Baraza, said that if someone asked him, is there any lesson that we learned from the pandemic, he would say nothing. Yeah? The things that occurred, we already knew they were there. but we never took any actions. So he is a bit uncomfortable of saying that there was some lesson. He said, no, these things were all clear. We were simply unprepared. What would you say briefly to that comment?
Right. I think to a great extent that depends on the capacity of the health system to be able to like respond to an emergency. And that would require, on one side, the ability to be able to like scale up its financing as well as all the resources, including the manpower, including technology that can be immediately deployed to respond to the pandemic. And I think if we look at like, some of the experiences of the other African countries where, we have had like, previous epidemics and pandemics like the Zika and the Ebola. And I think from there, there might be ways in which countries can definitely prepare better in terms of trying to understand how some of the resources can be maybe put in a contingency fund so that they can be deployed at a time like this. And also trying to think about ways in which, as we think about developing the capacity of our health force, how can we already start like preparing them in terms of like trying to respond to a pandemic and trying to utilize their skills, not just to maintain health services, but also to deploy them towards, things like, testing and contact tracing and things like that. And I think technology in today's day also plays a very key role in terms of how that can be utilized in using it to kind of quickly ramp up some of the responses to the pandemic. So yes, I mean, I think like we have had like many cases of pandemics happening across different countries, but the way in which we incorporate some of the lessons and try to build them more sustainably into our health system would be most important. Thank you.
Thank you. Thank you. Peter, I hope you can hear us. This one I want you to tackle. Is Kenya ready for the transition from donors? This is from my colleague Josephine Mbiu from Population Services Kenya. So that's one part of the question. What should we put in place as a country to prepare for donor transition? Peter, if you can try that, and Joseph can also chip in.
All right, thank you very much. And hi, Josephine. It's been a long while since we last saw each other. Are we ready for to take on domestic resource mobilization and funding? I think we have a choice really, because you see what happens is, as a country, if we choose not to put public resources towards providing health services, which is actually a social, a public good, then individuals are then forced to actually get from their own resources, and you end up experiencing a lot of out-of-pocket expenditure, and that actually leads to detrimental outcomes, not only for health but also for the economy. So what I would say is that we have to, it's not really a choice that countries are faced with. It's actually more of action needs to be done. And the second thing is that this action is not just to substitute what's currently being provided, but also to increase the amount that's being provided towards certain, well-established thresholds. I think there's work that has shown that 5% of general government expenditure should be directed towards health-related work. In fact, it should actually be more than that, heading more towards 15%. The country right now is headed towards about 9%, if I'm not wrong, in the most recent expenditure budgets. But they still need for more money to be allocated towards general government expenditure to health, and this is this is a prioritization process, as the Honorable Cass mentioned. It's a prioritization process, and there's a lot of work going on right now to encourage the priority setting mechanisms in the at the institutional levels, in the ministry, and even in other sections of government. But this is a negotiation that continues, requires political goodwill, as was mentioned. And there is a lot of there's a lot of discussion points that can be done over here. Counties need to be empowered more. The facilities need to get more autonomy so that they can be able to use these resources to provide these services, and so on and so forth. Maybe I could get over to Joseph.
Okay, thank you. Thank you very much, Peter. And the concern around the question has also been taken note of by the global community, and most particularly the World Health Organization. And in the next couple of months, our team here, led with Professor Kokwaro and Professor Gavin here, Peter included, myself and the colleagues who are here, will be having a candid engagement with the healthcare fraternity and the community within the healthcare to really redefine our approach around how we are going to get into this transition phase, and then find out what will be the most cost-effective mechanisms around which we will continue to finance and deliver healthcare services. So the debate is already on, and this is going to relook at the whole framework of transition. So again, we will be reaching out to you for recommendations so that we front this to the global community as well. Over to you, Prof.
Thank you, Joseph. And back to you, Peter. There is a question here from someone has posted. Team Chege, team is actually from our team. This is to you, Peter. Did you explore, or are there plans to incorporate budget impact analysis in your cost projections?
Thanks for that question, and thanks, Prof, for the chance. Team, yes, we did not go towards the point of doing a budget impact analysis yet, because at the moment, the next steps that we have for this work is to work closely with the task force Child with Transition to harmonize these estimates, to add on the gross estimates of costs from a program level, from above service level, at which point then we could actually apply these results to and compare with the current budget. As we look at the outputs right now, you can notice that the estimates are way much lower than what is currently allocated towards health in the country, and that's because of the missing pieces. The infrastructural investments, the certain human resource development estimates, and certain other program coordination and so on costs, which are better suited for gross costing, while this tool is really useful for ingredient-based costing based on an underlying demographic and epidemiological projection.
Thank you, Peter. This is for you. If you don't mind, there's a question from one of our students, Gerald Odero. This was, how has COVID-19 affected the health sector globally, and how is it likely to recover from it, from the student? So you want to have a go at this?
Thanks, Dr. Kokoro, and thanks for this question. So I think at the global level, in short term, the COVID-19 has disrupted many essential services. Evidence show that the routine health service, including TB, HIV, maternal child health, vaccination programs, are experiencing different level of disruption. However, in the midterm or long term, we believe if our if government pay more attention or the political will, and if we improve the efficiency of health sector, there are some opportunity to address the challenge caused by COVID. So I think the future is still quite promising.
Thank you. There is another question, and I think, Joseph, you have a look at this. This is all to do with the human resource, and it comes from Eric Nyaga. I think Eric is in the audience. How do we recover from the the effects of COVID-19 when COVID has taken away the jobs? Joseph.
Okay, thank you. Thank you, Prof. That's a human resource for health question. And as we are aware, Kenya is classified among the 57 countries that have shortage for human resource for health. And we understand that part of this constraint has been further expanded through this pandemic, where we have either lost healthcare workers, healthcare professionals, and the numbers are increasing. But beyond the number of healthcare workers that are lost through the attrition of either succumbing to the pandemic or other health-related issues, there is much more around this, because looking at our pipeline in terms of what are we able to bring from the pre-service into in-service and into post-service, again, a concern there. So we are essentially sitting on a time bomb. So we must look at that. But beyond that, even the ones that are existing, our main concern now is the mental health and the well-being of the current workforce. Again, another aspect that we must start thinking of how to deal with it. So again, we know the situation in our country. We have a number of healthcare workers who are not either absorbed in government or are in private practice, but how can we have a collaborative perspective of which we absorb the healthcare workers, and how do we grow our pipeline? So the problem will be feeding into the pipeline that generate the next workforce for the healthcare workers, but also the time bomb of the current healthcare workforce that we have to deal with the mental health and the well-being of their status as they keep on working through the strenuous system that we have. Over to you, Prof.
Thank you, Joseph. I think we have about 8 more minutes for Q&A. Let me read one of the questions, and this can be either any panelist, maybe Peter or Ken. So it's one from Kemal Hussein. How effective are the counterpart financings compared to donor/partners financing? How can we make them sustainable? Ken? Has Ken gone?
No, I'm here. I was just thinking through. I mean, how best to respond to that? So I guess that is one of the questions, and that is unfortunately one of the things we were not really able to look at in terms of, the efficiencies or inefficiencies created by donors participating in a particular space. So this will be one of those things that does need exploration and is being explored actually, as the CAS mentioned. I know Professor Baraza's team at Kemri Wellcome Trust are focusing on these issues in terms of inefficiencies, and I know the WHO Kenya office is also looking at cross-programmatic efficiencies. So that is an area that can be explored. In terms of whether one form of financing is better than the other, I mean, I pick something. There's something Joe Katzen says that health financing is not particularly fun or interesting or innovative. It's pretty simple. Governments have to put in more money into the system. It's like that simple. So the solution is quite straightforward. The government needs to put in more money.
Okay, Ken. Don't go away, Ken. There are quite a number of people really interested in financing. Don't go away. Don't get tired, Ken. Kemal, again, is back to you. Total costing for NCD, was it? No, Peter can probably do this. This is Peter. So no, you are off the hook. Peter, total costing for NCDs, was it the same as for other diseases?
So Good question. No, what I would say is, so for NCDs, what we ended up doing is we selected the most prevalent NCDs, because you see there's a whole battery of possible interventions to address non-communicable diseases. So we selected the, actually there were six most highly prevalent NCDs in the country, which you probably can guess are cardiovascular diseases, mainly hypertension and related complications, diabetic conditions, management of diabetic conditions. This is medical management of diabetic conditions, and then medical management of cancers of the breast, cervix, and esophageal cancer, and colorectal. And then in addition to that, we looked at management of asthma and chronic obstructive pulmonary diseases.
Perfect, thank you. We have 5 minutes. Unfortunately, we don't, 4 minutes before I wrap up. Oh, sorry, Peter, had you finished?
Yes, indeed.
Perfect.
I had finished.
So we have 4 minutes. I just now want to go through each of the panelists. I give you 1 minute each to just say your final reflections. We start now with Wenju. Just 1 minute. Your final reflections or comment.
Yeah, thanks for this event and the excellent speech by our panelists, and also the questions from the audience. My reflection on the transition in Kenya, we can see there are many challenges, but also there are opportunity with some approach to mitigate the risk. I hope Kenya will be more sustained in health sector and provide the universal health coverage for the whole population.
Thank you, Wenju. Iptita, final reflection, 1 minute.
Sure, thank you, Dr. Kokwara. First of all, thank you to the entire team at Strathmore University for putting together such an excellent webinar. I think in terms of Kenya, it is really at a cusp of like donor transitions, which also has its risk, but at the same time, I think with COVID-19, there's an opportunity to better prioritize the health sector and think through how to use and leverage some of these like bilateral, multilateral organizations, as well as its own lessons from the pandemic about how better to prioritize the health sector, integrate the health services in a way that can bring down out-of-pocket spending and improve public spending in healthcare. So we hope that some of this work is going to help contribute to that. Thank you.
Thank you. Peter, 1 minute.
Right, thank you very much. I think what I can say is that what we're finding is that there's a lot that has been done and that is currently being done, especially at the institutional level, at the at the national government, and also with the county governments, especially the county health committee, working closely together with the national government to brace themselves and to increase resources that are allocated towards health. As they plan for the rollout of the UHC scheme, there's a lot of work that's been done around research, especially looking at work around domestic resource mobilization, around pooling, around even work around strategic purchasing and purchasing for quality, work around improving efficiency in the health system. And I think the idea is to build more onto this work, because there is good work going on. And I think we've seen political goodwill across board. And I think the only way to go now is to increase on the efforts. Thanks.
Thank you, Peter. Ken, final thoughts on this?
So, yeah, I guess the main focus really has to be on making sure, people can access services and they don't experience financial hardship. And if we keep it, the focus on, that goal and on keeping it simple, we should get there by 2030.
Thank you, Ken. Joseph, you have 30 seconds.
Thank you very much, Prof, and thank you, our distinguished participants in this webinar series of policy dialogue. I think that we are actually within a very interesting time at this particular time, and all the pillars of the health systems are shaken. And with that, we have a golden opportunity to redefine our mechanisms of how we are going to deliver healthcare services going forward. And with that, all the stakeholders then have to put their hands in this so that we are part of the conversation and we redefine how we are going to manage our healthcare systems here domestically as we work with other international partners and other countries to ensure that our people's well-being is taken care of. Thank you, Prof.
Perfect. So, ladies and gentlemen, we are coming to a close. So, mine now is to wrap this discussion. But let me just acknowledge the presence of one of my colleagues. Heather, I did not acknowledge you. My apologies. But Heather is one of our colleagues from Duke. Now, on behalf of our colleagues from Duke, led by our own able Professor Gavin Nyame and Osondu. Osondu, we have not seen your face. And the rest of the Duke team and the Strathmore team, this is the research team, we want to thank you very much for participating in this webinar. We really appreciate your time and we look forward to further interaction with you. We want to take this opportunity to particularly thank those among you who participated in our questionnaire, and we are really grateful. We promise to share with you the results. That promise is still there. We are still finalizing the final publication. So thank you very much again. Now to our participants, we thank you very much for again sparing the time to join us in this discussion. You are still free to get in touch with us through the contacts that were listed there. Please share your thoughts, comments, and questions. We didn't have enough time to actually go through, but that does not mean we have closed the dialogue and the discussion. Please feel free to do so. So we thank you very much, and we will be sharing you further publications that come out of this. And we hope that you will again join us in the next webinar, which we'll plan in the next near future. On behalf of Strathmore and my dean, Dr. George Njenga, I hope he is in the audience, who gave me delegated authority to actually preside over. We really want to thank the Strathmore University management for supporting us to organize this, and also giving us all the encouragement and creating that atmosphere for us to do. So we thank you. And last but not least, for our colleagues from Ministry of Health, we really appreciate the way you have interacted with us, and we look forward to working with you in this journey and also the other aspects that we had not had time to cover them. And the panelists, thank you very much again for a job well done. So without too much ado, I think our time has run out. Let me just again take this opportunity to thank all of you. Those of you who are proceeding to travel for Easter, please keep safe, and we look forward to interacting with you in the near future. Thank you, and bye-bye.